All right. So hip fracture, as we all know, mostly this condition mostly occurs in adults. Okay. And once we have fracture, obviously we are going to have shortening of the affected limb. Okay. And severe pain as well. We may have disruption of blood flow. Okay. That will result. Okay. So when there's reduction in blood flow, because there's fracture, so when you compare the two legs, it won't be the same. You can see that the affected extremity will be what? Shorter than the what? Unaffected one. Okay. Especially when the bones slip past the where the injury is. Okay, you can see that that leg or that affected leg is shorter than the unaffected leg. That is a sign to you that the person is having fracture. And once there's fracture, severe pain, and because there's blood vessels around, it's going to disrupt the flow of blood. Once there's disruption of blood flow, what will happen? The blood won't get to the extremity and it will cause what? Necrosis, femoral head necrosis. That is what we call avascular. Avascular means that the disruption of the blood vessel. Sometimes if there's a break in the blood vessel, okay, and the blood will not supply the end of the femur, leading to what? Avascular necrosis, meaning that there's death of the tissues. All right, that is what is going to happen. So what do? We do frequent assessment. Frequent assessment. Okay, and that is the major risk factor is what? DVT. Okay, so once it happens like that, we have to do surgery for the patient. Okay, and I told you also that there's going to be dislocation. That is one of the commonest concern after surgery. Okay, that's what I told you. Dislocation. Because once they connect the joint, it can dislocate from what? Inappropriate handling of the patient. So if dislocation occurs, what are you going to see? Pain, okay? And a whole lot, all right? There's going to be a lump in the buttocks, okay? Because you can see that the head, it just, you can see that the head is at the buttocks. You can see it, okay? So when you palpate the buttocks, you're going to see that the bone is dislocated, okay? And when there's a dislocation, we know that there's going to be a shortening, okay? So if you're anticipating that there's dislocation, obviously you're going to prepare the patient for surgery, and you have to keep the patient NQ. And once the surgery is done, ambulation is also important to prevent DVT, okay? So anything that has to do with the use of the legs or the affected leg, you have to avoid, okay? And also aim at avoiding what? Infection. So anything that can cause infection, like using tap water, okay, or tap bath, okay, can lead to infection. And when you don't avoid driving or any activity that will lead to dislocation, you have to avoid all these things. Okay, that's what we said the last time. All right. So we talked about this, okay. And today we are looking at total knee replacement. But before then, let me show you something. Let me show you something. How we can see this? Can you please see the screen?
Yes, please.
Okay. Supposing that you can see that there's a prosthetic device applied to the hip. Supposing that, let me use the other image so that you can see it well. Let's suppose that this area is a hip. Okay, this area is a hip. When it turns inward like this, okay, towards the center, what is it called? It's called what?
Adduction.
That is internal what? Rotation. Okay, so and looking at the one on the left, if it turns towards, okay, outwards, that is what?
External.
External rotation. Okay. So supposing that there is internal rotation, meaning that the leg is pushed towards the center. What will happen to the hip? It will the hip, where we have what's the name? The surgery. Okay, because there's a joint at the hip. Please, I'm using the knee as a hip, okay? Because this person is not lying down. That's why I'm using that. So if there's internal rotation, you can see that the joint or the femur, okay, will push outward towards the hand, isn't it? With this. I hope you can see it. Can you see what I'm pointing to?
Yes, please.
So when there is internal rotation, it moves towards the center or to the other leg. This hip, okay, will be removed from the socket and point towards the what? The hand.
The hand.
So it means that when there's internal rotation, what happens to the hip? It moves on. There will be a posterior what? Dislocation.
Dislocation. Okay.
Do you understand? That is posterior. Means that the joint that we are seeing here will move towards the hand. That is a posterior. So you can see once, if it's the buttocks, you can see the lump there at the buttocks, the hip there. When you palpate. Do you understand, please? And when this happens, the other one, this one, when it twists towards the person who is holding, okay, that is, we have external rotation. Please, who is that? I will remove this so soon.
Mayor Hospital.
Go ahead and sleep. Okay, sorry for that. Okay. So what I'm saying is that if there is external rotation, okay, or external dislocation, what happens to the hip? Will it move towards the center or away from the center?
Towards the center.
Pardon?
Please, is it the hip or the leg?
Listen again, please. When there is external rotation, okay, external rotation, what happens to the hip? Will it move towards the center or away from the center?
Towards the center.
Towards the center.
Towards the center. And that is called what? As internal rotation. So depending on the dislocation type, whether there's internal dislocation or external dislocation, that will depend on where the hip will move towards. I hope you understand the concept. Are you okay?
Sir,
When the
please,
hip,
can you come again? Please, I didn't get that so well. Please come
okay.
again.
What I'm saying is that supposing the knee is the hip, okay, and the leg, it moves away from the center. It moves away from the center, as you can see, moving away from the center. What will happen to the joint here? Will it shift towards the center or away from the center?
Okay, towards the center.
Towards the center. And that will be what? Internal what? Rotation. Okay. So once there is
Please, why internal rotation?
okay, because look at the where he's moving the leg towards. You see, the person is moving the leg away from the center. I hope you can see that, my boss. Can you see that? It's moving away from the center, isn't it?
Yes.
The bone here, assuming this is the joint, the femoral joint, when it moves, this leg moves outwards, the joint will come inside, isn't it?
Yes, sir.
The joint will, so the joint will be removed from the sockets and come towards the center of the person, like towards the perineum. Do you understand, please?
Oh, yes.
So it means that when there's what's the name? External dislocation, the joint will move internally. I hope you get it.
Yes,
And
yes.
with this one,
Yeah.
when there is the joint, the leg moves towards the center, it means that the joint will move away. I hope you understand.
What's
Yes,
wrong?
sir.
Yes, the joint will move away. So it means that if there's internal rotation, okay, or internal what dislocation, what happened to the joint? The joint will move out of the socket and point towards posteriorly. You understand, please?
Mm.
Yeah, Sister Jane.
But Frank, please, I'm confused. The where the cursor is right now, this oh the previous one. So please, where the cursor is right now,
This one.
it means that there is anterior dislocation of the hip, and there will be
Yes, so
external rotation
that will
of the
be
leg.
yes. But the leg
External
will move
rotation of the leg.
outwards. Yes, so the once the leg moves outwards, that's external rotation of the leg, and the hip will what? Be internal dislocation. It will be
Anterior
dislocated
dislocation or
internally.
internal?
The hip dislocation will be internal dislocation because it will move towards the center.
Okay.
You
Internal
understand?
dislocation.
So if we rotate the leg outside, that's externally, okay,
Okay.
the joint will be removed and point towards the center. So external rotation will lead to what? The internal dislocation. Because of the anatomy of how the head of the femur looks like. I hope you understand this concept.
I understand though. Maybe it's the times that is confusing me.
The term is confusing you, eh? External.
said where you with this one, where the cursor is, I know that the hip is going to shift towards the center or
Yes.
internally.
Yes.
That one you said it is internal dislocation or anterior dislocation.
That one is internal dislocation.
Okay, but the second one where
This one.
the
Are you
leg
talking about
would,
this one?
yes.
So once
So this one,
the leg moves towards the center, okay, then
that
the
is
hip,
internal.
internal, yes, okay, internal rotation. So it means
Internal
that,
rotation
yes, the hip is going to move out of the socket and
towards
point
the
towards
hand.
the hand. Yes, and that is what? External dislocation. It means that
Dislocate. Ah,
it has
yo, thank
dislocated
you.
from the joints.
Thank you. I now understand.
Do you all understand, please? This one is another topic. Okay, how the head of the femur looks like. Do you understand, please? Are you okay?
Boss Frank, please, last one.
Okay.
Last explanation, please.
I should come again with last explanation.
Yes, please.
Okay, I will. What I'm saying is that look at assuming this is the hip and we've operated here. If you move the leg outwards, that is external rotation, going out external and going inside is internal. If we move the leg outwards, that is external rotation, the hip will be displaced and move towards the center. And once the hip comes out of the socket, we call it what? Dislocation. So that one will lead to what? Internal what? Dislocation. If we move the hip, the leg externally. So once we have external rotation, we are going to have internal dislocation. How is understood? And if we move the leg internally, so once we have internal rotation, we are going to have what? Posterior dislocation. Okay. So we are going to have posterior dislocation, meaning that the joint is going to move out of the socket and point towards the hand. That is the posterior, meaning that it's going back. The joint will be removed and move towards the hand posteriorly. So it means that if we have internal rotation, we are going to have a posterior dislocation. And if you have external rotation, you are going to have anterior dislocation. Is it understood?
Yes, boss. Thank you.
All right. So it means that with hip fracture, depending on the rotation, so whether internal rotation, which is going to lead to what? Posterior dislocation, or if you have external rotation, you are going to have what? Anterior dislocation. I hope that is understood. So it means that after surgery, our priority, one of the priority is what? To prevent dislocation. That's why you don't have to sit, you don't have to bend more than what? 90 degrees. Do you understand? Because if it happens, it's going to be removed from the sockets. All right. So that is what you have to know. And when we come to knee replacement, we can have an injury to the knee. Okay. And we can replace the knee with prosthetic device. All right. So we are saying that a compression dressing may be what? Used to immobilize the knee. So when there's a knee fracture, we have to what? use a compression dressing. So they will wrap around the knee with the compression dressing just to immobilize. Because over here, we don't want to move the leg anyhow. If we do so, or if we don't immobilize the knee, there's going to be what? Dislocation. I hope you understand. So we use what? What do we use? Compression dressing. So after surgery, you see that they wrap dressing over the knee. Okay, that is compression dressing. We want to use what? Immobilize the knee. Okay, and we want to keep the knee in what? Extension. So straighten the leg, okay, and immobilize with the use of what? Compression device. If unable to perform straight leg raise, then a knee immobilizer or posterior plastic shell to what? Maintain extension may be used. So, because our main focus is to maintain the leg in extension position by using what? Compression dressing. Okay. And what do we do? If we are saying that we should use what? We should maintain the knee in what? Extension. Okay. So what about if the person is going to bath? What are we going to do? It means that we have to use what? Shower chair. Okay. Grab bars because we want to prevent dislocation. All right. So let the person sit on a shower chair. When the person is moving around, you have to use bars. Okay, you know, grab bars, the one that we can hold when we are walking. When we are moving like upwards. Okay, on a stair. Raise toilet seats. Okay, and what? Assistive equipment to help with movement. Use non-skate footwear because we want to prevent fracture again. So the footwear should be what? Non-skate. The one that is not, the one that doesn't cause what? Slipping. Okay, and avoid leg dangling. I hope you understand dangling. When you are sitting at the edge of the or on your bed, okay, you see that your leg will be hanging. Okay, so we want to avoid that and perform what? Weight-bearing exercises with assistive devices. So when we want to do exercises, use assistive devices. And avoid activities that will place stress on the prosthesis. Okay, like what? Running. So we have to avoid that. Don't have to run when you have knee replacement. And another name for knee replacement is what? Knee what?
Arthroplasty.
Arthroplasty. So running, jogging, high impact sports, you have to avoid because we want to avoid dislocation and fracture, refracture. But with swimming, that one wouldn't put much stress on the joint. Okay. So, and that one is even done when the wound is healing. And cycling is also good. But we avoid leaving the continuously bent for prolonged period. So we don't have to bend the knee for prolonged period of time. Okay, so that's what you should know. And if we prescribe, we can also prescribe continuous passive motion. Okay, continuous passive motion exercise. When it started, you should administer analgesics before we do that. So continuous passive motion exercise. Okay, gradually, you have to exercise, but before then, because of pain, you have to give analgesics. Okay, and once the patient is going to be discharged, your priority is what? Home safety. If the patient is being discharged, your priority is to make sure that the home is safe for the patient not to have any fracture or dislocation again. So during discharge, your priority, or when the patient is going home, your priority is what? Home safety. Please take note of this. But that is, we are looking at joints, we are looking at fracture. Okay, as I told you, our one major concern after surgery is what? Dislocation. Okay. All right. So what do we do? Sometimes we can do amputation. All right. Once there's an amputation, they are going to wrap up. We've all seen amputated leg before, right? I hope we've seen it.
Yes.
Yes. After surgery, what did they do? They have to wrap, okay, the stump. That's the remaining leg. That's the stump. Okay. They applied surgical tourniquet. Okay. And they apply it. Why are they applying all these things? You get to know it. And another thing is that we have phantom limb pain. Phantom limb pain. Okay. So that sometimes the patient will not understand why is the leg up. And patient might feel real pain, or sometimes because the leg is not there. Okay, patient assume that there's pain. Okay, so what do we do? So we have to place mirror. So we are going to see a reflection of the what? The leg. So the person will see that I have two legs. But in reality, the leg is one. So when you do mirror therapy, by the person seeing two legs, the patient will be okay and the pain will reduce. Sometimes it's both physical and psychological pain. That's a phantom limb pain. Okay, so by placing mirror and the person seeing the mirror, we see that I'm having two legs. I hope you see what I'm talking about. And we want to also prevent hip what? Flexion contractures. Especially if we do above knee amputation. Once there's above knee amputation, or once there's amputation, if the patient is sitting down on a bed, what happens? The patient sometimes tries to flex the stump. Okay. And that one will cause hip flexion. It will affect the hip. And over time, we see that the hip is in a flexion position. And that will be remain there for life. Okay. That is a contracture. So we want to prevent hip flexion contractures in what? Amputation. So what do we do? Do not elevate the residual limb on a pillow. So if you want to prevent hip flexion contractures, I hope you understand what I mean. So let me show you how it is so that you understand it very well.
Hello.
Yes, please.
Hello. Yes, sir,
Yes,
please, I
please.
can't hear you.
Yeah, I'm coming. I'm
Yeah,
showing you
please, I
something.
can't
Okay.
hear you.
Yeah, I'm not
Okay.
talking. I'm coming. Okay. I want to show you something. Okay. How you can see this? This one, you can see that the person is sitting on a wheelchair. And as you can see, the stamp is in what? Extension position. Okay. If we raise the stamp, that means we are flexing the what? The knee or the stamp. Are you getting it? So sometimes they will flex, that's the once the stamp is moved upwards, that's flexion. Okay. And if it happens like that, most of the times it will form a contracture. It will be there. When you want to extend it, it won't happen. Because one of the major complications after surgery is what? Hip, what? Flexion, what? Contractures. So know the complication of each. So that once you are managing, you know that I'm managing for this. So because of hip flexion contractures, we don't do what? We don't do what? Elevate
the leg.
elevate the residual length on a pillow after surgery. But what do we do? If you want to elevate, why are we elevating in the first 24 hours? Because right after surgery, there's going to be what? Edema. So for the first 24 hours, elevation is allowed. Because you know from previous slides, I told you that edema can cause what? Edema can cause what?
Compartment
Compartment syndrome. So in the first 24 hours, you want to avoid that by raising the stamp on a pillow for the first 24 hours. Please know the timing. Only 1 day for stamp. So 1 leg, 1 day for stamp. And then once the 24 hours elapses, okay, what do you do? Position the patient on prone. Because we want to have extension, not flexion. Yes, Sister Precious.
Yes, but Frank, you mentioned what is on the slide is elevate the foot of the bed. But you are saying place it on the pillow, so I don't understand. Is it the same thing?
It's the same thing, please. Either you raise it on a
Okay.
pillow or raise the foot end of the bed. Is the same thing. We have to raise. The motive is that we raise in the first 24 hours to prevent edema. But
Okay, thank you.
afterwards, we don't have to raise again. So after 24 to 42, the first 24 hours, you don't put the patient in a prone position. The first 24 hours, our priority is to prevent edema. Okay. After the 24 hours, then we want to prevent hip flexion or contractures by placing the patient in a prone position for what? After the 24 to 48 hours, post op, we want to still prevent what? Hip flexion contractures. So that's what we do. So if we want to prevent hip flexion contractures, 1, we don't elevate. 2, we place the patient in a prone position. Because when you lie on your abdomen, what happens? Your legs will be straight. Okay, so no flexion. So that's the main idea. And we have to also the stamp. What do we do? Because sometimes they need artificial leg. That's the prosthesis device, right? So our motive again is to prepare the stamp for what? Prosthetic device. But not the initial 24 hours. That's not our motive once the patient comes from surgery. Once the patient comes from surgery, our motive is to what? Right after surgery, our motive is to what? Prevent.
compartment.
Yes, that's later, but our right after surgery, prevent edema from coming. Okay. After 24 hours, you want to prevent what?
Contractures.
then the subsequent days, our care should prepare the stamp for what? Artificial leg. To know when we know the timing, when a question comes, you'll be okay. You know when that right after surgery, my priority is not to prepare the stamp for prosthetic device. I hope it's well understood.
Yes,
So that's
boss.
what, once you know the complication, once you know what I want to achieve, that's the way to go. Once you know this, NCLEX becomes quite easy. Okay. So maintain elastic compression. I hope I told you that we apply what? Surgical tourniquet. Okay. And over there, we are also trying to prevent bleeding. Okay. You maintain elastic compression wrap to reduce swelling. So that tourniquet, that's elastic compression device that we apply on the stamp is also to reduce swelling and pain. Okay. And mold so another reason for the elastic compression is to mold the residual limb in preparation for what? Prosthesis. Okay, want to mold it, want to modify, make the stamp fit well into the what? The artificial leg. That's the prosthesis. I hope you understand. So we have to maintain the elastic compression. Want to reduce swelling, want to reduce pain, we have to also prepare the stamp for prosthesis. Okay. And the residual limb, we wash with what? Mild soap and water. Once it's healed, okay, we have to wash. Okay, we have to wash with what? Mild soap, because that place, they've covered, there's not going to be any wound. Okay, they've switched it. All right. So we have to wash with what? Mild soap and water. You also massage. Why? Because if you don't massage, a time will come, the limb or the affected leg or that stamp will not be put into use. So if your muscle is not in use, what happens to the muscle? Atrophy. You understand? So we do what? Massage. Okay, we do massage the skin and we massage towards the suture line. Why? Because we want to let the skin cover the suture line. So we massage towards the suture line and prepare the residual limb for prosthesis. Okay, with what? Resistive technique. So what do? Sometimes it's like when you see the foot end of the bed, we have a bar. Okay, that's when the patient can use that one and push the stamp against that one. That is all resistive exercise. Okay, so once you push towards the bar, or sometimes you can just give the patient something, push the leg, the stamp towards that. And that is what? Resistive exercise. So that once patient start walking, because we've already put the stamp into exercise. So once patient starts using the prosthesis, it will be quite easier for the patient. So we need what? Resistive technique. Okay. So in preparation for the limb of prosthesis, we use what? The elastic compression. In preparation, we massage. In preparation, we use resistive technique. Okay. And we have to discourage for prolonged sitting. It should be less than 1 hour. Patient shouldn't sit for long. Why? You want to prevent what? Hip flexion contractures. Okay, that's the whole thing. So sitting for long is discouraged. Not more than 1 hour. Okay. And you have to also place sandbags, rolled towels along the outside of the thigh to prevent external rotation, especially above knee amputation. I hope you understand external rotation, right? Because when the after surgery, we can see that they will be they want to move the stamp away from the center. Okay, so what do? We place a sandbag, okay, or roll towel. You get a towel, you roll it, okay, and place side on side, okay, to keep the leg or the stamp in a neutral position in the middle. Prevent external rotation. We don't want the patient to move the leg outwards, away from the center. All right, so that's what we do. And we have assistive device. So when a question drops on amputation, either below or above, you can still do it. Okay. All right. And we have assistive devices that we can help the patient to use. Because as I told you that when we are the studying patient, our motive or our priority is to prepare patients and to prevent what? Fracture in the house, accidents. So we need assistive device when the patient is going home. So we need canes, we need crutches, we need walker. Okay, depending on the patient's strength. We need gait belts. We need mechanical lift. We need wheelchair. All right. We need friction reduction or devices. Okay. We don't want to be over here in our setting here. If we want to push the patient up, what do? We just push the patient just on the bed. Okay. And sometimes friction will occur and cause an injury to the skin. So if we want to lift, push the patient up, we lift. Okay. So if we want to transfer the patient from bed to other bed, we use the slide or transfer board. Okay. So these are all assistive devices. I hope you all know cane. Do you know cane? The normal cane. Okay. You know crutches. Crutches, the one that they put under the armpits, isn't it? And we have walker. I hope you know walker. Do you know walker?
Yes, boss. Yes, boss.
Okay. If you know that, that's fine. Gait belt is just normal belt. We want to help lift the patient, and that's it. Okay. And we have mechanical lift and wheelchair as well. So cane. We can have a cane that has 4 foot. Okay. I don't know. Let me.
Hello.
You can see that the cane has 4 legs or foot. Can you see it? That's the quast cane. Okay. And this one provides more stability, more than the one that has only one. Okay. All right. So we are coming to learn. Okay. Let me show you this one. I hope you've seen the walker, right? That's the walker. Okay. That's the walker. All right. So then the crutches is the one that we put under the armpit. So back to this. For cane, if we need limited assistance, so this one, if you can use cane, it means that you need just limited assistance, okay? With what? Balance, okay? Or sometimes you have mild weakness, so that we can give you cane, all right? So it's held at where? So mind you, before this, always, as a nurse, where are you supposed to stand? Is it where the problem is, the affected or unaffected leg?
Where the
The
problem is,
affected,
The
where the
affected
problem is.
leg.
affected, the weak part, the affected part.
Yes. So we assume that the nurse is always at the affected leg. So if you are the nurse who is one leg or one support at the affected leg, where will the cane also be?
The cane should be at the strong side, the unaffected side.
So it means that we have two things, okay, two supporting systems. The nurse always at the affected leg and the cane at the unaffected leg. So you see where the cane should be, right? So when the cane is, we ask you about cane question, where it should be, the unaffected leg, because always the nurse is at the affected leg, supported. So that's what we should know. So the cane is always at the unaffected and handle. So we have the handle, the top, where they have to handle. It should be at the level of what? The waist. That's the hip. That's the greater trochanter. Okay, that's where the level should be. It shouldn't be above the greater trochanter, or it shouldn't be below. Always at the level. And it means that if it's at the level, if you hold it, by all means, you see some fleshing around the elbow. Okay, so the fleshing should be around. If it's always at that level, it means that we are going to have a fleshing of what? 15 to 30 degree angle. I hope you understand what I'm saying. Do you understand, please? If you don't understand, please draw my attention. Because that's the reason is to help us pass. So if you don't understand anything, please draw my attention so that this one, we don't need to memorize it. It's just something you have to know. Okay. So if you don't understand, just tell me and let me explain to you. You wouldn't memorize them. So the cane always is just about few inches away from the leg. Okay, just about 10. You see our old ruler, the smallest ruler that we've been using. Even that one is about what? Is it 30 centimeters, right? So the smallest one. You see that? So it shouldn't be quite long. The leg, the cane should be quite long away from the unaffected leg. Okay, about 10, 15 centimeters to the side of the foot. Okay, always make sure that the tip of the cane, okay, is not what? What do you have to inspect the tip of the cane for?
Damages.
Yes, it's not damaged. That's why sometimes they have to put a rubber tip, okay, just to prevent accidental slipping. Okay, so always before patient moves, inspect that tip. Okay, so it's about that making sure it's placed well, the size is okay, okay, and the tip is also okay as well. All right, and stand at the affected side. That's the next. Okay, so cane means that cane moves first, bad leg, and the good leg. Mind you, this one is not about chewing. Just understand that. Always, the bad leg is not going to go first, or neither is it coming last. Okay, the bad leg is always at the middle. So your supports will go first, and then the bad leg, then the good leg comes. So always when we are walking, cane plus the bad one, it's got what? The good. So always the bad leg should be at the middle. Don't ever move the bad leg first. And never leave it behind. Because if you leave it behind, it means that if you are walking and you leave whatever leg that you leave behind, that is where the weight is going to bear on. It's going to experience the weightest, the heaviest weight. Okay, so we never leave it behind or go first. All right, so the cane plus the bad one equal to the good leg. I hope you understand the principle. It's about moving, okay? When you're moving, you move the cane. Then the cane is always at the good one, the good side. So the cane goes, and then, because when you are moving, you move left, right, left, right. So if the cane is at the right side, where that's the good side, it means that the right side, which is the cane, will go, and then the left foot goes, and then the right leg, which is good, will go last. I hope you understand. Okay. When we are going upstairs with a cane, okay, we've developed a principle that's always the bad leg will go first or go last.
First.
Hey,
The
the
good
bad
leg.
leg.
The good
Where
leg.
should the bad leg be?
In the middle.
In the middle. It neither go first nor last. I just told you. Hello, are we there?
Yes, please.
Don't go and miss the questions, okay? It's very simple. Once you know that the bad leg, yes, you understand very soon. Don't worry. Okay. So when you are going up, I've already told you that the bad leg always should be at where?
The middle.
The middle. So when you are going up, you always go up with the good and come down with what? The bad. But that doesn't mean that coming down with the bad doesn't mean that the bad leg should come first. The cane first, the bad, and the good. I hope you understand.
Oh, yeah, okay.
I hope you understand. Going upstairs, we go up with good. When you're going to heaven, good. When you come down, bad. So go upstairs with the good. We come downstairs with the bad. But coming down with the bad doesn't mean that the bad leg should step first.
Okay, first.
I hope it's simple.
Yes, boss.
Yes.
All right. Let's move on. So we are done with going up the stairs and coming down. I hope it's simple.
Yes, please.
Okay. So when we are coming down, which one comes first?
The
Bad.
cane.
But they came first.
The cane first.
The cane
Then
first, and what next?
the
Followed by
bad.
the bad
And
leg.
the good.
And then
And then the good.
when we
The
are going up, what comes first?
The
The
good.
good.
The good
Good
leg.
leg.
Bye.
and the cane and the bad.
But
The king.
Hey, who is saying the cane and the bad?
So it is bad,
The bad never comes
good,
last nor
and
first.
king.
Sister, let's be careful. The bad, it never comes first nor last. So don't tell me that good, cane, bad. No.
so many up is good, then the bad and king.
Yes.
Wherever you are going, either up or down, the bad should always be at where?
At the middle.
The middle.
At the middle.
Okay.
But just know that if you are going down between the bad and the good, always, if we don't want to go with the bad, but the cane, if we want to come with the bad one first, it means that the cane will come before it. I hope you get it. The cane will come before it. So when we are coming down, we say we come down with the bad. It doesn't mean that the bad leg should come first. What will come first?
The king.
And what follows?
The bad leg.
Always the
And
bad leg is in the middle.
Yes, the bad leg will never be the first nor the last. Just know this principle and you are good to go. But just know that
So,
we go up with good, we come down with bad.
so does it also mean that the cane is always the first?
Is it?
No.
No. The cane is never always the first. But one principle that you should know that the bad leg should never be the first nor the last. So if you are going up, we go up with what? The good. So it means that the good leg goes first, followed by what?
Affected leg.
The affected, followed by
Cane.
cane. Because the bad leg will never come last. When we are coming down, we say we come down with the bad. So what will come first?
The cane.
The cane, followed
The
by
bad leg,
the bad leg, followed by.
then the strong leg.
It's not simple.
Yeah.
Okay.
But it means the thing that become better to you.
It's not
I don't get
basa. This one here.
No, it's not basa. It's not
What makes it
basa.
basa? Tell me.
Sir Frank, I think everybody should try it. You get a cane, then you try it to stick better. Because
Okay, let me ask my sister, please. What makes it basa? Let us know. Or I should repeat myself.
Yes.
I should repeat that.
And I have
We should
my
go for
grandma.
our mock stick, then we use it as an
Okay.
example.
One principle
Yes.
to understand is that there are two principles here. One, the nurse always stands where?
Affected.
Affected.
So if the nurse stands at the affected side, that's one principle that you should know. So once you know that, the cane will come where? The opposite side.
Opposite
At
side.
the unaffected
That's
side.
one principle that you should know. Another principle that you should know, the bad leg will never come
Always
first
at the middle.
or come last. That's another principle.
Yeah.
If you know this principle, you are good to go. You don't have problem.
You move the cane with the bad leg, then the good leg will come.
Assuming we are walking, we are not going up or we are not going down. We are on the floor. So which one will go first?
So your question again.
The good leg goes first. The cane will go first.
The cane.
The cane will go first. Then
When we
the
are just
bad.
moving on the floor, just like that, the cane plus bad equal to good.
Bad leg, then the good
Cane
leg.
plus, so on the floor, cane.
So the
Okay.
cane will go with the bad leg.
So
Then
the
the
cane,
good leg will come.
they won't move, they won't move together, but cane goes, then the what? What follows?
the bad leg.
The bad leg will follow.
The bad leg and the cane moves. Okay? And the good leg follows.
Ahead.
Do you understand?
Yes,
When
boss.
we
Yes.
are on the floor, we move together because when you are walking, your hand, your right hand and the left hand, the left leg, they move together, right? When you are walking, the right hand, left leg, they move together. The left hand, right leg, you also move together at the same time, isn't it? So when we are on the floor walking, it means that we should go in 2-2. So the cane and then the bar, because mind you, the bar will never come last. So once the cane is going, it means that it's going with what? The bar. So cane goes with the bar, and then the good follows. When we are working on the floor, they go together. Cane, bar goes together, and then good follows. When we are going upstairs, another principle is that we go up with the good. So when you are going upstairs, when you are going with the good, it means that the good leg goes, so it's left with the bad leg and the cane. Which one will follow?
Bad leg and the cane.
The bad leg.
Yeah, the bad leg should be at the middle and the cane last. If you are coming down, You are coming down with a bad. But I told you that one principle is that bad will never be last or first.
Which
So if
method?
you are coming down with a bad. What are we coming with first? Hello, sister. We want to go and sleep. When we are coming down with a bad, the cane comes first, followed by what?
The bad leg.
And then lastly,
The good leg.
oh, now it's not basa again.
No.
Can we move on?
Yes.
Boss,
All right.
please, I have a question.
Okay.
Please, when you are moving the cane forward, is there an inch that you should ensure that the cane moves as compared to the walker? Does that principle applies to the cane too?
With the cane, that's why we are saying that with the cane, if one want to use a cane, it means that the person has limited what? Assistance. Okay. Though we should not walk as if our usual walking. No. But it doesn't have anything to do with go to that extent or that. But we go like our normal pace, but we don't go as we move the legs so wide. Okay.
Yes,
but the one
boss.
thing is that whenever you are walking, you have to look down on the floor or look forward. Our normal usual thing. When you are walking, do always look down.
You look forward.
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 You look forward. Yeah, you look forward. So the same thing applies to cane. Once you are moving, just look forward. Please, if your baby is disturbing you, please kindly mute your mic. Okay? Now back to walker. Walker, as we saw, it has 2 wheels, or it can have what? 4. Okay, the one that I showed you. Okay. And sequence of walking, same as cane. Maintain an upright position and look forward rather than looking at the feet. Never use the walker as a puller. So if you are sitting down, you want to rise up. Don't bear weight on the distance, or don't pull. Don't try to pull on the walker to help you stand. No. Always try to come at the edge of the bed and stand up, okay, before you hold the walker to walk. Don't use it as a helping aid to rise up. Are you okay? So that's why we don't tilt it to help you ride. No. Okay, if not, you fall down. So scoot forward. So we have to scoot forward, push up from the bed. So just come to the edge of the bed, okay? Or if you are in a chair, okay? You use the armrest to help you stand, okay? And once you maintain your balance, then you grab the walker to walk, all right? And don't climb with a walker. Walker, it has that 4 connections or 2 connections. Don't climb up with it. You use the cane. So it means that if the person is using this, because it's in order, cane means that we have limited. When we move to walker, it means that you need more assistance, more than the cane. So we don't go obsessed with walker. And position the hand bar below client waist. Okay, with elbows slightly flexed. All right. So that's what you should know, is that walker and cane, the same thing. So if you are moving on the floor, okay, cane or walker with what? The bad leg and a good leg pull. All right. Crutches. Crutches is what we put under our armpits. Okay. So we have that armpit pad. Okay. We don't rest on it. So the principle is that you never lean on it. don't rest on it because we have nerves there, we have blood vessels there. You can occlude the blood vessels and can cause injury to the nerves at the armpits. Okay, so don't rest on the parts, armpit parts. Okay, don't rest your body on it. No, you want to prevent nerve compression. Rather, weight should be supported through the hand. If you want to lift yourself, you have to use your hand, okay, to grasp the handle, not the armpit pad. All right. So we have what you call the hand grip. So if you want to bear weight, you should hold the hand grip to bear it on the hand grip, not the armpit or not the armpit pad. Okay. Distance between the axilla and the arm pieces should be at least 2 to 3 fingers.
This one, okay.
Please note that the armpit pad, okay, or the arm piece, okay, that's the where it ends, okay. It shouldn't go all the way to the armpit. No. At least when you have 2 or 3 fingers, those who do the VE, I hope they can understand me. If you're doing VE, okay, you put your 3 fingers together or 2 fingers together. So between the arm piece and the armpit should be at least 2 to 3 fingers width. Do you understand the concept? I hope you understand what I'm saying.
Yes.
Yes.
Yes, boss.
All right. Hand grip. I hope you know the hand grip I was talking about. The hand grip. So we have the arm piece or the armpit pad. That's why we are saying that it shouldn't reach the armpits. At least 2 to 3 fingers weight away from the arm. And then when you want to bear weight, where? On the hand grip. Okay. The hand grip, where should it be? It should be at the waist level. It should be at the hip, like the cane. But the cane, we said it should be at the greater trochanter. The same thing applies to the hand grip. It should be at the hip. All right. And once you know that with the cane, you should have flexion of the elbow. The same thing here. Okay. But this one is a bit the angle is a bit longer than that of the cane. Okay, because this one we need to bear weight. So it should be at least 20 to 30 degrees. Okay. Always the neck should stand at where?
Affected side.
Affected
Which side?
Okay. And when you are walking, look forward. And place crutches 6 to 10 inches diagonally in front of the foot. So when you are going, you don't need to move the crutch too long away from you. Okay, at least 6 to 10 inches. Okay, diagonally. Okay, that's what you should do. And stop ambulating if you are ambulating. All right, because sometimes this one we need more assistance, more than the cane. So sometimes patient can become dizzy, patient can feel tingling sensation because you are using the hand to bear weight. So sometimes because of that, you experience all this. So when it happens, what do? You stop. If a patient is walking and experiences numbness or tingling, it means that the patient cannot no longer feel sensation on the hand. So it won't help with bearing the weight on the hand. So quickly, you stop the patient. So when you are sitting down, what do? You move the crutches to the affected side because that needs support. So you remove one crutch from the other armpit and you add it to the other one where the affected leg is. Okay, and grasp the arm like you are walking. Okay, arm of the chair. So once you move the the other one to the affected one. It means that the other side where it's not affected, it becomes empty. So what do you use the hand to do? You use that hand to grab the what? The chair. Okay. And then the two crutches will be at where? The affected side. Okay. So that's what you should do. And you flex the knee. So once you do that, your good hand is supporting it's being supported with the bed or the chair. And then the other affected side has the two crutches, okay, being happening with the support. So if once you do that, then you flex the knee. Okay. On this one, mind you, we are looking at if there is your patient is having knee fracture. So it means that we shouldn't bend the good one, because the good one, we want to, as I told you initially when the patient comes, we want to straighten it, want to be in an extension position. Okay. And it means that when you are sitting down, you need to flex the good one and extend the bad one. Do you understand? You need to extend the bad one. The bad one shouldn't be flexed. Extend it. So raise it and extend it and flex the good one so that you can go down and sit. Do you understand what I'm saying? Okay.
Yes, boss.
When you are going upstairs with a crutch, okay, going up, step unaffected leg up. So what goes first?
The good
The
leg.
good one.
The good
Leg
one,
first.
followed
Same
by
as the cane.
The
yes,
bad
followed by
leg.
The
the
bad
bad leg, and the crutches will come last. It's not simple, because the bad one should never be be in front of at last. Okay. The same thing when you're coming down, we come down with the bad.
With the bad.
But that means that the affected leg will come first. The cane comes, the affected, and then so that's it. All right.
So, boss, does this same principle applies to the walker?
Walker.
No. You
Walker
can't go
is
upstairs and
you
downstairs
can't go
with
up.
walker.
Yeah, I just said it. Very good.
Okay.
You can't go upstairs with walker. You go with the one with only one piece or two. Okay.
Okay.
That means the cane and the crutches in your armpits. Because if you put a walker in front of you, that one, it has multiple what's the name? Pieces put together. So that one there, it means that we need a lot more assistance. So you can't go up with that.
So, boss,
Okay.
please, with that one, will the nurse stand behind, or that one to the nurse will stand at the affected side as
The
compared to
same
the...
principle.
Yes.
Oh,
The
okay.
same principle. Always the nurse should be at the affected side, because that's why the problem is. So if patient will fall, it will come from the affected side. Gate. Crutches gate. Okay.
Boss Frank,
Yes, please.
sorry, please. I just want to ask a question.
Okay.
So when it comes to the cane, the going up with the crutches, it look like you just substitute the crutch to where the cane is. And then that
When you are
same
going up,
principle holds. Yes, when you
you
are
say what?
going up.
Yeah. So when
Please,
you're
I
going, go
said
up with
when
the
you are
good.
going up with a cane, it's always good, affected, and then cane. Same
Yes.
with the crutches. It's still
Exactly.
good, affected, and crutches.
Yes.
Okay, thank you.
Up is good, right? This one there, I don't think you forget. Or you will.
No.
Anyway. All right. We have okay. Someone say let's pay attention. All right. Anyway, crutch gate. Okay, crotch gait. We have 4-point gait, 3 points, and 2 points. What does it mean? Over here, we are looking at crotch. Crotch, the one that is put under the armpits. When you are moving, sometimes we move both legs. Sometimes we move one leg at a time. Sometimes we move one leg. All right. So that is what we are coming to do. Okay. It's very simple. So please pay attention. All right. Are you here? Someone says pay attention. So pay attention. All right. Okay. Let's move on. 4-point gait. When you see all these things, it means that there should be a number of either the leg together with the crotch should be on the floor. So it means that 4-point gait, they're going to have 4 things or 4 items on the floor. So the crotches are how many? The crotches, they are how many?
There are 2.
There are 2.
Together with your 2 legs, making what?
4.
4.
So it means that 4-point gait, all the crotches together with your legs, they should be on the floor. None of your legs should be hanging. Not the affected leg. Okay, that's why we call it 4-point gait. You should have 4 points on the floor to help you with your balance. That's the whole meaning. 4-point gait. 4 things should be on the floor. That's points to help with your balance gait. All right. So 4-point gait. What are we using? So 3-point gait. How many points should be on the floor?
3.
How many points?
3.
3.
Always make sure that the 2 you can move and you hang your crotch. Can you do that? So the crotch there, always they should be on the what? On the floor. So if 2 crotches are on the floor, it means that one leg will be moving and the other leg will be what? Hanging. I hope you understand.
Yes.
All right, so let's move through it. So 4-point gait, it means that this one provides the greatest stability because all the 4 points are on the floor. So weight bearing on both legs. I hope you understand because both legs together with the crotches are on the floor. So we are bearing weights on the legs, both affected and the unaffected. But with this one, we are walking slowly. We are walking slowly. So know this. There's one common principle. If you know this, it won't be difficult. All right. The principle is that both. So over here, okay, let's finish with it. So if you are moving, you should go with right touch, left foot, left touch, right foot. Are you here? Are you here? Always.
Yes.
When you are on the floor, the crutches should be moving first. It can move with the leg, or if it's moving alone on the floor. When you're not going upstairs, you are just on the floor walking. Which one should always move? Which one should always move first?
The crotch.
The crotch, right?
So that's one principle. Either the affected or unaffected will depend on the gait. But a principle that I want to establish here is that the crotch, when you are walking on the floor, The
Yeah,
crotch.
boss.
Yes, please.
Thanks.
You want to ask the person on contribute. Hey, sister, you want to go and sleep? Go and sleep, eh? Who is that? The sister is mixing me. Please talk and let me see you. Okay. So the 4-point gate, always the principle is that which one goes first?
The right
crotch.
leg, the right crotch.
The crotch. The crotch moves. Okay. So sometimes the crotch can go with the affected. It's like when you are using a cane to move on the floor. When you are using cane to move on the floor, always cane, good, cane, bad first. And then the last one would be what? The good leg. I hope you understand that. When you're moving with a cane, cane plus the bad
Then
moves,
good.
and then good moves last. So the same principle. So when we have 4-point gate, means that all the 4 items, all the 4 points are going to be on the floor, but slowly. So right crotch moves, because mind you, the crotch. Right crotch moves. When you are just walking, at normal circumstances, when you are walking, when your right hand move, I hope what follows? They move together with what? The left, isn't it? When
The left leg.
yes, it means that if you move right crotch, you're going to move the left side. Okay, you're going to move the left foot. And once we move the foot, then another crotch comes. And then the first one, we move the right foot. So the next one, we're going to move the left. And then the right foot comes last. It means that the foot, the left set, the left, both left comes in the middle. So with 4-point gate, both left comes in the middle. Just have go and sleep, okay? Good night. All right. So if we have 4 points, someone want to follow. If we have 4 points, always the left comes in the middle, right? And the right will be at the side. So if we are moving the crotch first, always the crotch moves. So crotch, right crotch, then go to left foot, right crotch, left crotch, and then right foot. Know that the left comes in the middle. Yes, Sister Jane.
Boss, please, with the 4 points, is it always a must that the patient has to start with the right crotch?
The
Or
4-point gate.
it depends on, yes, or it depends on the person, as in whether the person is left-footed or right-footed.
What you have to know is that please try to mute yourself, okay? I beg you, mute yourself. If you're not talking, just mute, because you might not know when you will talk, okay, unintentionally. Will end up to be removed. Okay. All right. So always know that we want to start with the right crotch, but notwithstanding, you can also move with the what? The left. Do you understand? But if you want to move with the left, know that the left, which one comes first? Is it crotch or
The
the foot?
left crotch, right foot, right crotch,
Always the
left
crotch
foot.
will come first.
Okay.
Do you understand? If you want to move with the left, that is going to turn.
Okay. So it
All right.
depends on which one you start with or the
Yes,
question.
yes, please. So
No, but
sometimes it can just
please,
ask
when
you.
it's left crotch, the next will be right foot.
Yeah,
Or
it will turn. So it be left crotch. Okay. So when the left crotch comes, what will follow? Then
Right
left
right
foot.
foot.
Yes, right foot. And then right crotch
Right
and
crotch, left
left
foot.
foot.
The left foot.
Yes. So know that left will be in the middle, but start with the crotch. Start with the crotch.
For right
So
will be in the
crotch,
middle.
I mean, with the normal circumstances, yeah, when you take it like this, the left will be in the middle. If you want to move with the right crotch first. Do you understand? So, Joyce. So, Joyce.
Yes, yes. Sorry, I had an issue on meeting. So I wanted to ask a question that the right crotch and then the left, like as in those, do they both move simultaneously
No,
or it
with
follows
4
each
points,
other?
with 4 points, okay, with 4 points, know that we are moving one at a time. One at a time. It's like the normal walking, okay? The normal walking. So we are going to move the right crotch, and then we move. Then that's why we said this one is slow. Once we move the right crotch, a crotch comes first. Then once a crotch comes, a foot is going to follow. And we know that left should be always in the middle. So if we are moving the right crotch, then we need a foot. But that foot will be left. And once we move that left, we also proceed with another left. But because we moved, a foot has already been moved, it's going to be a crotch. Okay, so that is how it goes. So left will be in the middle, but always know that we are going to move the crotch first. Are you okay? Now, 3-point gate. 3-point gate. How many items should be on the floor?
3.
3. Okay. 3-point gate. We have to know that. Please, someone should mute. Please mute it. All right. So, with a 3-point gate, the 4 points, we are saying that we are moving one at a time. But with the 3 points, we need to add them. Okay? 3 points, we add them. So 3 points, we add what always comes first?
The crotches.
What always comes first?
The
Hello?
The crutches.
So if we are adding 2, with the 3, we are adding 2 at the same time. One must be left behind. Please, someone should mute yourself. Mr. Grace, please. All right. So 3 points, we add what? 2. And one must be left behind. Which one do you think will be left behind? The good or affected?
Good.
The good.
Good.
So if we are adding with a 3-point gate, we add 2. So a crotch and the what? A crotch and the what?
The affected leg.
Is equal to good. I hope it's simple. And
But
2-point gate, we also add them. So 2, 2. So apart from the 4-point gate where we move one at a time, the rest we add. So 3-point gate, we add 2 is equal to 1. 2-point gate, we add 2 is equal to 2. You understand? So with 2-point gates, what we do is that we add 2 is equal to 2. So what comes first? The crotch. Okay, so the crotch comes. So over here, it means that if we are adding 2 is equal to 2, this one, we don't have the affected or unaffected. We are looking at, it means that we can move 2 at a time. It means that the person can bear weight, a partial one. You understand? So it means that crotch plus the left leg is equal to left crotch plus the right leg. You understand? Are you okay?
yes.
Or I should go over? Are we okay?
Boss Frank.
Yes, please.
So with what you've taught so far, it means that if the person is on the floor or a leveled ground, it means that whatever the person is using as an aid will go first. Then the affected leg will follow,
Yes.
and then the good leg. But then when the person
Always
is
the
climbing up, is always the
yes.
case. But when the
When
person
the
is
person is on
climbing
the
up,
floor, when the person is on the floor, always K. But when the person is going
okay,
up, we go up with the good. But coming
okay.
up, we come up with the bad, but the king first. When
Coming
we are
down,
walking, yes, when we are coming down, we come down with the bad, but king first.
yes. Thank you very much. I think it's okay.
When we are on the floor, always king first. Always king first. Whether you are adding them or whatever, king. It means that once you know that always king first. So let's do some mathematics here. I just want to test you here. When we are walking, we say always king first. So with 2-point gate, 2 is equal to what? 2-point gate, 2 is equal to what? 2. And 3-point gate, 2 is equal to 1. And 4-point gate, 1, 1, 1, 1, 1. Just understand that principle. 2-point gate, 2 is equal to 2. 3-point gate, 2 is equal to 1. So, and 4-point gate, 1, 1, 1, 1, making 4. So, if
Hey,
we
but
are,
Frank, I don't get it. Oh,
you don't get
the
it.
way it's equal to this. I understand the whole concept, like the way you taught us in when we are moving at the level ground, the crutch or a cane would always come first, and then we move up with the starting with the good, and then we move down starting with the bad. But the affected side will always be in between. But then this is equals to this is equals to this is what is confusing me. I don't get it.
You don't get it. Not. Let me get it.
But
What I'm saying is that
we have it on our dashboard. So after this, we can all go and also take a look at it.
okay. Just get a video so that you understand it.
Yeah, we
clearer.
have the video there.
But what I want to teach you is that 4-point gate, because 4 points are on the floor, and that one 4-point gate, know that we move 1, 1, 1, 1, 1. You understand? But when we are moving 1, 1, 1, 1 on a level ground, what always goes first? What always goes first?
The
The
crotch,
cane,
so right crotch.
the cane
Yes.
or the crutch.
The crotch. So over here we are looking at crotch gate. So we are referring to
Oh,
the crotch. So the crotch goes first. So let's do some analysis here. you are doing 4-point gait. So if my right crotch goes, what will follow?
Left
left
leg
leg.
will follow.
Left
Left foot.
leg or left foot. Once left foot goes, what will follow again?
The right crotch.
Left cross.
Hey, sister, I told you that left should be in the middle and right ends. 4-point gait. Left always in the middle and the right at the ends. So we are starting again. Always cross first. 4-point gait. 1, 1, 1, 1. So I move my right crotch. What follows?
The left
leg.
foot.
Left foot.
Left
foot.
foot. When my left foot goes, what follows?
Left
Left
cross.
Left
Left
cross.
Left
Yeah.
crotch.
So we are having the left in the middle. And what will come last? So we are having crotch. So what will come last?
Right
Right
foot.
leg.
Right foot.
Right foot. Okay. 2-point gait. 2 move together is equal to 1. 1 will be at the last. So what always should be at the last? The good or bad
The
leg?
good leg.
The good leg.
Good.
So we are saying that 3-point gait, we move 2 at the same time. So if you are moving 2 at the same time, it means that we are going to move crotch together with what?
Affected limb.
Affected leg. That is 2. Crotch together with the affected leg at the same time. That's why we say 2. Then is equal to what?
The good leg.
The
Good
good leg.
limb.
The good leg will come last. That's 3-point gait. 3.2 is equal to 1. Now we are going to the last one. 2-point gait. 2.2 is equal to what? 2.
2.
So we add 2 is equal to we add 2. So 2 move together at the same time, and then 2 that is left backward will come at the same time. So it's almost similar to the 4-point gait, but just that 4-point gait will move 1 at a time, but 2-point gait we move them in 2s.
Yeah.
Do you understand?
Yes, please.
So in 2-point gait, let's do the calculation. 2-point gait, we say 2 is equal to 2. So let's start with, and always start with what? A crotch. So if you are going with a left crotch, or let's go with a left crotch. So left crotch plus what?
Right
Right foot.
leg.
Right
cross.
is equal to what?
Both legs.
Hey, please come again. I'm getting
Please come
confused.
again because my memory.
Look at it here. I'm saying that with 2-point gait, we move a crotch and a leg together.
Yeah.
So crotch and a leg together is equal to crotch and a leg together.
Together.
2-point gait, 2 is equal to 2. So it's crotch and a leg together is equal to 2 crotch and a leg together. So it means that if we are moving with the right crotch, so it means that a leg should be added. So what leg will be added? The opposite one.
The left.
The left is equal to what? So if we move the right crotch here in the first side of the equation, when we go to the other side, what will come first? The
left
crotch.
Left cross.
But the left, that's the left
Please,
crotch.
it's like when we are walking, we walk, when you raise your left hand, then the right hand will come
Yes.
together.
Yes.
Like that.
The same thing. So 2-point gait, 2 is equal to 2, but it goes in opposites. So a boy and a girl go together, a boy and a girl go together.
Yeah.
Do you understand?
Yes, please.
4-point gait, right always at the extreme, left in the middle. But note that we move the crotch first. 3-point gait, 2 is equal to 1. So if you are leaving 1 at the back, we can't leave the affected leg. You have to leave what? The good leg. with a 3. 2 is equal to 1. So it means that we are moving a crotch together with the affected is equal to the foot. Is it understood, please?
Yes, please.
It's not easy.
Left in the middle.
Yes. The affected leg in the middle. I hope it's understood, right?
Yes.
Yes, yes, please.
Okay. So just know that your calculation. If 4-point gate, 1, 1, 1, 1, 1. But left be in the middle, right, a street. If you know this, you're always good to go. It doesn't matter how the question would be. If 3-point gate, 2 is equal to 1. And 1 that is left, we all know that the one that is left at the back will never be the affected leg. So it means that the first 2 will be a crotch and a affected leg. And when we are going to 2-point gates, we are going to 2 is equal to 2, but we move in opposite. A crotch and a leg, a crotch and a leg. As simple as that. Are you okay?
Yes, boss.
Okay. We have string 2 gates. This one we are still using the crotch, the one in the armpits. That one has the gates. Okay. String 2 gate. So it means that if you are swinging is what? Like you are tossing yourself. You are moving the air, right? So if you are swinging, it means that the 2 crotches will be supporting, will be on the floor. But the 2 legs will be swinging in the air. You understand? That's swinging. When you are swinging something, you are just moving in the air. They don't touch. Okay? You're not going to move it one like as we do the other one. But this one, we move the 2 legs at the same time. You hang it in the air and then just move towards where the crotch is. So swing 2 means that we are not bypassing where the crotch is. So it means that always what goes first? What goes first?
The crutches.
The crutches will go first.
So it means that the crutches, if they are going first, it means that we are moving the crutches together. And when we are swinging through, we are not going to bypass where the crutch is. So crutch will move first and we leave it there and move the 2 legs at the same time and move it at where the crutch is. That's swing 2. Through means that we are going through. We are going through the gate. So we bypass where the crutch is. It's not simple. I hope it's okay. Are you okay, please?
Yes.
Yes, please.
It's as simple as that. Assistive device. So that's the crutch. So the crutch has gates. 4-point, 3-point, 2-point, swing 2, swing through. All right, assistive devices. This one assistive. They are all assistive devices. The crutches and the walker, the other things, they're all assistive. They will assist us. And the device, the belt, is like the normal belt, but because this one is put placed around the waist. So that when we want to lift the patient, you hold on the belt. Patient is walking, you are walking by the side, you are standing at the affected side, you help by what? Supporting the belt. The patient by holding the belt. Okay. So applied around patient waist over the clothing. Okay. The patient will wear clothing first. It's like a normal belt. We wear clothing and the belt will come afterwards. Okay. So we use the gate when patient is standing up. We use that one. You hold it and help the patient stand. When you are transferring, the same thing. Or when patient is ambulating, you are standing at the affected side and helping patient ambulate by holding the belt. Okay, and we have slide or transfer board. Slide board or transfer. So it means that you are using it to transfer the patient. Okay. And this one, patient can't walk. It means that patient has limited mobility. Mobile means moving. So patient has limited moving. So we are using the slide board or transfer board to help. Okay. We have bed. We have so if you are moving the patient from bed to wheelchair or wheelchair to bed, we can use the transfer board or slide board to transfer. So the board is for transferring. The board is for transferring. And then we have the wheelchair. You all know the normal wheelchair, but normal wheelchair, it has something in front where you have to place your legs on. Okay. So always be careful with that. Okay. And always make sure that the ties are also good and are in good shape. Okay. And if you are moving, okay, says stable patient first. Whenever you want to move the patient from a bed onto the wheelchair, please make sure the patient is stable before you transfer the patient.
But
So
Frank,
sometimes
over here, it's written stable surface first. So, I mean, I don't
hey,
know. Maybe it's a
stable,
typo.
yeah, sorry. It's the same thing. Okay. Either stable the surface, we are looking at the whether you've locked your distance, your chest, right? I hope we lock it, right? You lock the wheelchair. So you should stabilize it by locking it. And with the patient too, we have to make sure the patient is stable. How? That's why if you want to move the patient, if patient is lying down, we have to let the patient what? Sit. Sit first. And patient will move. Sometimes if we want to prepare patient for that, we will move, let the patient sit. And then if patient is able to sit at the edge of the bed, then we support. Okay, before we move the patient onto the wheelchair. So always make sure that if you want to make use of the wheelchair, make sure the patient is stable first. And two, the wheelchair, you've locked it, is stable before you transfer. All right. And the lift, we also use to lift the patient. All right. And that one requires high level for as assistance. Okay. When you are lifted, we all know when we are lifting patient. And mind you, assess safety first before moving. Whenever you want to move patient, want to ambulate patient, what is your priority first? Priority is what? Stabilize the patient. Make sure your patient is stable. Okay. So sometimes patient will have to come and sit at the edge of the bed, dangle the foot, okay, before you walk. So you sit down, you dangle, and then you assess the patient. You let the patient stand, you assess. So while the patient is sitting on the bed, assess. Is the patient conscious? Is the patient okay to walk, to ambulate? If patient stands, assess. Because sometimes you know that we have what we call autostatic
Hypertension.
Orthostatic hypotension.
Yes. Sometimes patient is lying down, you check your BP, the BP is good. Patient will rise up, you check your BP, you see that the BP has dropped. But mind you, that one, before we consider it to be orthostatic hypotension, means that the systolic should fall to at least what? 20 millimeter per mercury. So it means that if you patient is lying, you check patient what's the name? BP, you are getting 120 over 60 or 120 over 80. Patient stands, you check BP, BP has dropped to 70 or 80. How many difference? When in terms of systolic? 20. So 20 and above mean that you are having orthostatic hypotension. That's for the systolic. And the diastolic, if it drops more than 10. So 10 and above is also considered a drop in the diastolic. And that is what? Orthostatic hypotension. So if you are having a difference of the systolic 20 and above, difference in the diastolic 10 and above, is considered orthostatic hypotension. That patient is not safe for ambulation. So always before you move patient around, assess patient safety first. Know that. So you want to know if there's orthostatic hypotension. The assessment, the purpose is to know whether patient is having orthostatic hypotension, no patient is having dizziness, okay, or maybe balance, okay, or balance. If dizzy when you are walking patient, you shouldn't ambulate. You have to stop, sit down. Don't walk the patient back to the bed. Sit down first and reassess. It's the same thing. When you are walking around, patient falls. What do you do? What do you do?
You assess.
You assess. Please note. An assessment, mind you, if you assess, you just move around, you just move your eyes around, you don't see any bleeding. It doesn't mean that the patient has no problem. Because you know with fracture, you can have internal fracture. Okay? And you have open fracture. So when it's internal one, you won't see any blood. So assessment is not just only about surface assessment. You have to assess patient more. You understand, please?
Yes.
All right. And that's why I said after a fall, assess for injury. You assess for vitals and you obtain appropriate assistance. Don't move the patient alone. Get an assistance and remove. And this one, what are you going to do? You report. Whenever patient falls down, it's considered what?
Incident
It's considered what?
report.
Incident report. So always assessment first before writing a report. Don't go and write a report before you come and assess. All right, let's finish with this one. Home safety. As I told you, when patient is being discharged, your priority is what? Home safety. Okay, so we have to educate the patient about any rats, any clutter, any spills. Okay, sometimes you can spill around, water on the floor, any electrical force just across, okay, where the patient is walking. It can't be a risk. Okay, ensure that there's enough lights, appropriate footwear, and the footwear, it should be what? Non-what? Footwear. Okay, so that is, and frequently used items, it should always be accessible, easily accessible. Let it be at where the patient is, so that if patient want to use, because it's something that patient frequently uses. So all these things should be easily accessible. Prevent fall. That is home safety. All right. So that is what we are ending. Next time we are going to talk about vertebral dislocation. And we'll bring fracture to an end. Any question? Any question? All right. So with vertebral disc, this is what we are going to talk about. That's what we are going to talk about. So as you can see, there's a bone here. All right. This one is spinal cord. And this one the disc. The disc. Okay. And there's fluid here that cushions it. Okay. And then another bone comes down. All right. So when there's herniation, Okay, as you all know, the meaning of herniation means that it has moved from its original anatomical position to another place. So once there's a rupture here, okay, the contents, that the nucleus, okay, moves out. And if this helps to cushion the bone, it means that once this goes out, the fluid goes out, this place will be flattened. Okay. So there are nerves. Okay, nerves. That's supply the hands and the other places. Okay. So it means that there's going to be compression on the what? On the nerve. Do you understand? Do you understand?
Boss, please come again.
What I'm saying is that you've seen this disc. That's the disc that we're talking about. It looks like the old disc that they used to record songs of. Okay, you can see it. And it's filled with what? This one, fluid. Okay. And if there's an injury to the disc, what happens to the fluid?
The
What
fluid
happens to
will
the fluid?
come out. The fluid will come
It will
out.
leak out. It will
Yes.
leak out.
And it means that the bone, okay, below it and the bone above it will be very close because it was the disc that was helping the bone to be separated. Okay, and it helped to cushion it. So if the fluid comes out, it means that the nerves, because the nerves runs through the forearm, okay, the holes here. And if the nerves, the fluid comes out, it means that there's going to be the two bones, okay, both the one that is up and down will be very close, okay, and come together to compress on the nerve that's supplying wherever it is going. I hope you understand.
Yes, boss. Thank you.
Okay. So that's all about herniated disc. Herniated disc. All right. So if this herniation means that the fluid coming out, then it leads to what? Compression. Okay, on the nerve. All right. So that is it. So it happens when the soft inner part of the spinal disc, okay, that's the disc that we're talking about, in the neck pushes through a crack in the outer wall. All right. And what happens? This can press on the nearby nerves. That's radiculopathy, or the spine cord, that is myelopathy. Okay. I hope you know the radius. You know the radius is what? You know the radial bone, the bone. You know?
Yes.
Okay. So it means that the radiculopathy is in relation to the hand. Okay. The bone on the hand. All right. So it means that when there's nerve root compression, it's going to lead to what? The associated symptoms. That's paralysis, weakness of the limb, pain. That is what we term as what? Radiculopathy. So know that radiculopathy is the nerve that is supplying the hand okay, will be affected. Or the spinal cord, if it affects the spinal cord, that is the myelopathy. So this herniation, okay, will lead to what? Nerve root compression and radicular what? Pain in the arms. Okay, sensory changes because you're looking at the nerve. Once the nerve is compressed, pain results. All right, and sensory changes also happens. So it means that there's going to be weakness, numbness. Okay. Yes, and another thing is that the nerve helps. We know the nerves. It's in two ways. You have the motor function and what? And the what? Motor and
Sensory,
what?
sensory function.
Sensory function. Okay, so sensory, you're looking at pain, you're looking at numbness, tingling sensation, all right? And motor, we are looking at weakness. Okay, that is the radiculopathy that we are talking about. The hand. And even the muscles, anything, the nerves that supplies the hand, they are affected. It will lead to all these symptoms. What are some of the risk factors? Age. You know, as you age, okay, it can complicate in this, all right? And being overweight, it will put pressure on the spinal cord. Okay, sometimes genetics can play a role, leading to weakness of the spine, okay, the vertebra. And physically demanding job. Some people are working very hard, okay, in the work demanding is so high that they can get trauma to the vertebra. And trauma and smoking can be some of the risk factors. And we also have, how are you going to know if there is vertebral disc herniation or compression? So herniation is just the outpouring, okay, of the content. Okay, and once it happens like that, it's going to lead to a herniation and compression. So progressively worsening neck pain and stiffness. The neck becomes so stiff that it becomes very difficult to think. Right? And you shouldn't think it's meningitis. Sometimes you have to know the underlying cause, you have to know the other signs and symptoms to rule out other diagnosis. Okay. And there's also pain. And this pain is like an electric pain. Because nerve, you know, is like, it acts like the electricity. Okay, so electric pain, very sharp shooting pain. All right, that is the radiculopathy that we are talking about. Okay, and with the nerves, as we are saying, pain, tingling sensation, numbness into the arm. And from the shoulder, that is where the patient is going to experience the pain. All right, from the shoulder downwards. Okay, and muscle weakness. It means that the patient will have difficulty gripping things or holding things. Okay, so it means that there is going to be what? Loss of grip strength and difficulty lifting. You can't use that hand to lift because there's weakness. There's paralysis of that hand. Okay, or patient will be finding it difficult to push or even flex the air because in order to move the hand up, it requires nerves. It requires the muscles. And know that there's problem with the nerves, there's problem with the muscles. So very difficult to flex the elbow, to flex the hand through the elbow. And weakness of reflexes. So we have the bicep reflexes and reflexes. So Let me show you where the bicep is in the chest. So as you can see, okay, as you can see the bicep muscle, okay, the tricep muscle, the nerve that is supplying all these things. Very would mean that there's good weakness here, and patient can't flex their hand like this. Patient can't, okay, because of what? The nerve injury. So that's what we have to do. And if you're not making use of the hand or the muscle, what happens to it?
It will atrophy.
Atrophy.
Yes. Very good. So that's what is going to happen. Shrinking. That's atrophy. Okay. That's what is going to, because if it's not working, so it begins to lose its strength. All right. And okay, dropping objects. Patient will be dropping objects if you give something to the person, or sometimes the person doesn't know. We are trying to give something to the patient. The patient, the object will suddenly fall. Okay, and even that patient will find it difficult to button the clothes. Okay, and pour great strength. So obviously, anything that we use that hand to do, it's very difficult for the patient to do that. Anything that requires motor function or nerve function would be very difficult for such patient. Okay, so just know that nerve and motor issues, and know the characteristics of the pain, shooting, electric, very sharp pain, and the patient will find difficulty in what? Turning the hair. Okay, that's the neck. All right. How do we diagnose this? We have what we call, yes.
But Frank, please,
Yeah.
doesn't matter the symptoms that you will see in the patient. Is it associated with where this herniation has happened, or once there is this herniation, regardless of the place, you will see these symptoms?
All right, it's highly dependent. So over here, we are mostly concerned with the cervical. How we know the cervical or cervical?
Yes, please.
Yes. So mostly we are dealing with the cervical disc herniation. Okay, and I think we come to that, but just know that this one mostly is in relation to cervical. If it happens to the lumbar, we are going to have issues with the bladder function and then the bowel function. How we get it?
Yes, please.
Yes, so Boss Frank, so
Yes,
if I understand you, it depends on the areas where the nerves supply. So maybe if it's affected the cervical bones or the nerves, it's going to affect the places in the body where those nerves supply. Am I right?
exactly.
Thank
you. But Frank, it means pregnancy can cause this, right?
It can cause, but it becomes a predisposing factor. Do you understand?
Okay.
You become predisposed to that because with no pregnancy, movement becomes challenging for them. And it can just cause an injury to the spine. If they have an injury or if they fall. Yes, sir.
Okay. I am asking this because I'm at work with a certain woman, and after pregnancy, she finds it difficult to write. Her hands keep shaking, like fine motor skills, buttoning, writing. She finds it difficult. That's why I asked that question.
Yes, it's true. So it means that it's having problem with the cervical spine. Okay, that is the vertebra that you're affected. So if the patient is having cervical disc herniation and mostly C4, C5, sometimes C6, it will result in this. So we are going to experience radiculopathy. Okay, that's the symptom that you're talking about. And if it affects the spine, because sometimes you might be lucky that it won't have any effect on the spine. If not, that's why we are going to have autonomic what? Dysreflexia. It happens to the spine. Because once there is a break in that joint or in that root, it means that there'll be a challenge with the parasympathetic and the sympathetic nervous system. That leads to the what's the name? Autonomic dysreflexia. Okay. But if it affects only the nerve root, that's the periphery, supplying the hand, or if it's happening to the lumbar, okay, then patient is going to have effects with regards to bladder function and what? And bowel function. Up, you get it. So please, just know where it is happening. Just know where it is happening. You understand? So this one is in relation to the cervical spine. Okay. But this one is not a cervical spine injury. It's different from cervical spine injury. Not a spinal injury. We are looking at the nerve. Okay. So the peripheries, the peripheral nerves. I hope you understand my point. Do you understand, please? Do we?
Yes, please.
Hello, boss one.
Yes, please.
Can you please take that again, please?
Okay. What I'm saying is, it highly depends on the nerve that is happening. Okay. So when we have cervical disc herniation, all right, we are not looking at nerve. Sometimes we might have complication if the injury is so severe. Then possibly it's going to affect the what? The nerve, the spine. I hope you get it. If the injury is so severe, then it's going to have effects on the spine.
Okay.
But over here, we are just looking at the cervical disc, which has herniated. All right, affecting the nerve roots. But if it becomes so severe, the injury is so severe, then it will have effect on the spine. Because you know that once the disc is herniated, okay, if the injury is so severe, it can just cause an injury to the spine, the one that is in the middle. I hope
Yes,
you get
please.
them. So that's what it's going
Yes,
to.
please.
Okay. But when we talk of cervical disc herniation or lumbar disc herniation, that's the most common places that it happens. Then you're looking at the nerve roots. But if the injury is so severe, then it can have effects on the spine. All right.
Okay. Yes, please. Thank you.
Okay. Now we can move on.
Sir Frank, please, is there any way it can affect breathing?
It can affect breathing. If it's breathing, we are if it's going to affect breathing, then we are mostly looking at the spine. If mostly it affects the spine, patient has spinal injury, obviously it's going to affect the spine. But mostly it's about the peripheries. It's about the patient having problem with the hand. Okay, that's where I said we have radiculopathy. All right, and the myopathy if it affects the nerve. But mostly if the spine comes in, and depending on the area of the injury, that one can also have breathing.
The line is breaking.
Are you okay? Are you okay, please? Hello.
Hello, boss.
Please, is your question answered?
Yes, please. Thank you.
All right. So we have what we call a positive spelling test. Okay. And radiculopathy. All right. So sometimes we want to extend the head sorry. So when it happens like that, so what I was saying is that they turn the patient, they extend the patient head, okay, upwards. All right. And if they do that, they tilt it to the affected side and press on top of the head. And patient is going to extend pain, okay, or it's going to result in pain of that hand, all right, as well as the nerve supplying the hand, all right. So if you do that test and patient experiences pain, that is what we call positive spelling test, all right. And we have shoulder abduction relief pain. Sometimes I hope you know abduction. Abduction.
Yes.
Movement from the center.
Moving away from the center.
Yeah. So once they do that, the patient is going to, because we are trying to extend the nerve, stretch on the nerve. okay, and the patient will have pain. All right. So these tests we can do to assess, and we can also do MRI, CT to just know if there's herniation. All right. Please mute up, okay? Be begging.
Boss Frank,
Yes, please.
Boss Frank,
Yes, please.
please, the positive talent test. I want to get it right. You said you hyperextend the neck backwards and then you turn to the side.
Patient extend the neck. The examiner will extend the patient's neck, okay? And try to rotate, turn the head.
Okay.
You understand? Like you extend the head like that, and you rotate. You try to rotate towards the affected side. You understand?
Okay.
And they apply a small pressure or gentle pressure, okay, on the head. Just they'll press it down. So once they extend the head, rotate it towards the affected side, and having gentle pressure on the head, then the patient will what? It's going to produce pain. Okay, and that pain is going to radiate to that arm. That's what we call positive spalling test. All right, please, okay.
Yes, boss, I'm okay.
Okay. All right. So how are you going to manage this if patient is having? So over here we are looking at the cervical herniation. All right, and if it happens like that, you have to do assessment. Just want to know if there's pain or not, or if it's really as a result of cervical disc herniation. So we assess for motor function. Okay. If you do assessment and everything is fine, so you do assess for motor and sensory function. Once it's positive, then we have to support the spine, okay, with what? A cervical collar or brace. All right. So when we are assessing for motor function, we are looking at the patient's strength when gripping things. Okay, ability to move the wrist. All right. And when we are assessing for sensory function, we're looking at pain, sensation, the patient having paresthesia, the patient having numbness, tingling sensation. Okay. So we have to assess all these things and the reflexes that you're talking about. What are they? The what? Biceps and what? The triceps what? Reflexes. Okay. You have to assess all these things. All right. Just to be sure that you are dealing with what? Cervical disc herniation. So when it happens like that, there are three major things that is happening. Okay. Motor function problems, sensory function, and reflexes. All right. So we apply cervical collar or brace. All right. But it shouldn't be something prolonged, because if you do that, it will result in what? Stiffness of the neck. All right. And we have to modify the patient activity, because we are having weakness of the hand, also paralysis. So anything that has to do with the use of that hand. Okay. So it's about reducing pain and avoiding things that will cause more pain. I was talking about stabilizing the neck. That's one priority. Stabilizing the neck. Another thing is reducing pain. Another priority is what? Reducing pain. And another one is avoiding anything that will complicate the condition. Okay, or lead to other complications. So once you do your assessment, you know that patient is having cervical disc herniation, then you apply what? Cervical color or brace. All right, but we don't put it for a long period of time. All right, just to prevent stiffness. And you have to modify your activity. How? Because heavy lifting will lead to a lot of complication. So we avoid sudden head movement. Patient move the head suddenly. Okay, going to result in severe pain. Prolonged neck positioning. So over here, the nerve is not working depending on the severity of injury. All right. And if you prolong the head in the same posture, okay, you position the head in the same posture for long period of time, what happens when you are turning? It's like when you are sitting down, you are not moving. Sometimes once you try to move, you have pain. All right. So it's the same thing that is happening here. We have to avoid prolonged neck positioning. All right. We have to avoid prolonged neck positioning. You have to avoid extension. Okay. Forward head posture. All right. And maintain the head in a neutral position. That's what we should do. Okay. So once you do this, it's going to help the patient prevent a lot of complications. Do you understand? So that is what you should do. And we need bed rest to also reduce pain. Bed rest. Because if you put the nerve into activity, it's going to complicate the condition. So we need bed rest. All right. We also apply what? Heat, just to reduce muscle spasm. All right. And apply ice to reduce inflammation. It's like what we are doing with fracture of the bones. Okay. So we apply heat to reduce spasms and what? Ice to reduce inflammation. And we know we do physical therapy. All right. Physical therapy just for posture correction. All right. It's very, very important. Okay. And another thing that we can also apply is what? Cervical traction. Okay. You have to maintain the head and the spine in neutral position. Okay. And because of the spasms, we need muscle relaxants. An example is what?
Baclofen.
Baclofen or
Cyclobenzapine.
okay. All right. Or
Atocavamol.
okay. Or
Gabapentin.
okay. So with this, we do have to give the patient muscle relaxants, okay, NSAIDs, okay, and gabapentin. This one is for nerve pain, okay, and we give corticosteroids for inflammation. And with this one, sometimes they inject the medication into the epidural space, all right, because of possible inflammation which is ongoing. And sometimes they have to do surgery. And after surgery, look at where the spine is. Okay. So what do? We have to monitor for hoarseness. And if it happens, it's not an expected sign. If it happens that patient after surgery is not able to cough or having hoarseness of voice, what does it indicate? What does it indicate?
Compromise.
What?
Laryngeal nerve damage.
Laryngeal nerve damage. I said this last week. Okay. Laryngeal nerve damage. If after surgery, cervical disc surgery, okay, know that it's involving the neck. All right. So if you do that and after surgery, patient is having hoarseness of voice or inability to cough, then mind you, patient is having laryngeal nerve compression. Okay. And last week too, I told you that we don't apply anesthetic lozenges. Why? Why? Hello? Why don't we apply or we should avoid anesthetic lozenges?
It is going to further numb the area.
Okay. And if possible, the patient will be at risk for choking and aspiration. Okay. So if we do this kind of surgery, please try to avoid anesthetic lozenges. If patient is having sore throat, give just normal lozenges, but not anesthetic lozenges. If patient is having sore throat, all right. So please take note. So once again, with this condition, we are looking, so after surgery, we are just looking at what? Your priority will be what? After surgery, your priority will be what?
Airway.
Airway. Airway. So just know the condition where we are doing the surgery and know what's happening. So you know that after surgery, your priority will be airway. Okay. So airway, as I said, we don't have to what? Give anesthetic lozenges. Okay, that's one thing that we have to do. And another thing is monitoring for hoarseness of voice and inability to cough. So if patient is unable to cough, means that the laryngeal nerve is damaged. Okay, so monitor for airway. All right. And before surgery, yes, please.
So what you're saying is after surgery, if you assess and there is hoarseness it's a normal finding, but if there is inability to cough, you need to report.
No, that's not what I'm saying. I'm saying that if after surgery patient is having hoarseness of voice, okay, the voice is like that of a horse. Okay, the patient is not able to talk. All right, the patient is unable to cough. It tells you that there is what? Laryngeal nerve damage. Do you understand, please?
Yes.
So that is what you should know. Once the surgery done, you have to monitor the airway. Airway becomes your priority. Okay, airway becomes your priority. Very, very important. Okay, once there's airway, we are going to do surgery on the neck. Okay, airway becomes your priority. And the most important thing is you monitoring for hoarseness. You monitoring for inability to cough. You not giving what? Anesthetic lozenges. Okay. Know that if there's neck swelling or hematoma formation around the neck, okay, or patient having difficulty breathing, okay, you have to know that this airway issue once we have this surgery. Do you understand, please? And Afterwards, you jet towards what? Neuro. Do you understand? Neurological. Okay. Is the patient having sensation? The patient experiencing numbness? Okay. So that is what you should focus on. All right. So, and we have lumbar herniation. With lumbar herniation, what happens is that you're going to experience pain. You're going to experience muscle spasms. So whenever there's fracture, whenever there's this herniation, spasms is one of the commonest signs. Okay, and we know we use muscle relaxants when we are dealing with what? Muscle spasms. Okay, but mind you, some of the muscle relaxants, they cause what? Sedation. And some of them have what? What's the name? Will have withdrawal symptoms when you stop taking them. So that's what you should know. And with lumbar herniation, the patient is going to experience pain, muscle spasms in the lower back. Over here is at the back, lower back. Okay. And it radiates to the hip, radiates down the legs. It's like the one that is radiating to the hand. That is what? Radiculopathy. The radius. All right. And this one can also radiate to the hip, can radiate to the leg. Okay. And that is what? Sciatica. Okay. So that's what you should know. And pain is relieved by rest. Rest is very, very important. With nerve pain, you have to let the patient rest. Okay. Once patient moves, pain is aggravated. And like the other one, like the cervical disc herniation, lifting, straining, puffing will make the pain worse. All right. So it means that with this, you have to avoid lifting. Okay. So it runs throughout when patient is having spinal cord injury, when patient is having this herniation or nerve roots compression. You should avoid any activity that has to do with lifting or coughing or pushing things, those stuff. All right. So that is very important. Okay. How do we manage that? Heat, as usual, for spasm, ice for inflammation. All right. And sleep on the side with the knee flexed. So that's where you have to sleep. Always try to sleep on the side, either left lateral or right lateral, and you try to flex your knees. If you try to extend it, it's going to stretch the neck and leads to more pain. Okay. You also, like the neck, as we are applying traction or cervical collar or brace, with this, you also apply what? Pelvic traction. Okay, just to relieve pain. So over here, once it happens, if it's not having effect on the spinal cord and just the nerve root, then relieving pain is very, very important. Okay, relieving pain and trying not to complicate the condition. Okay, so it's about correct posture, like the one that it has to do with the neck. Okay, suddenly turning the neck around anyhow, should avoid them. Okay, forward head posture, you should avoid them. That's when we are dealing with the neck, cervical. But when it comes to waist, posture is also important here. Okay, so teaching the patient correct posture is very important. Okay, like what we are doing with the neck is we said prolonged what? Posture is not helping the patient, doesn't help. So the same thing here, okay, when you are sitting down for a long time, it's going to affect you. Okay, so when the patient is walking, when the patient is sitting, please, you should teach the patient correct posture. Okay, and because we are having problem with the waist, okay, or the lumbar, when you are lifting or when you are bending, you should also teach the patient correct way of what? Bending or lifting. Okay, and we should, because obesity is one of the predisposing factors, we also have to control the patient weight. Do you understand? Are you okay, please?
Yes, boss.
Okay. All right. And after surgery, we need also to what? Monitor urine, because we are looking at the neck. So at the neck, we are looking at what? Laryngeal nerve compression or damage. Okay. So when we have the lumbar, we are looking at bladder. We are looking at bowel function. So if you know your way around, okay, it becomes so easy for you. All right. So we have to monitor urine retention, just to make sure that the patient is not having any effects on the bladder. Okay. And paralytic illness and minimizing sitting. As I told you, you have to minimize. Prolonged sitting is not going to help the patient. Okay. So that is what you have to do. So with this, we are going to teach the patient about what? Correct posture, bending, lifting. What do we do? If you are bending or lifting things, what do we do?
You flex your knees.
You flex the knees. Okay. What happens to the back? What do we do to the back?
You keep the back straight.
You keep the back straight. Please take note of it. The back should be straight. Okay, or should be in a neutral position. And when you are bending, we bend with the waist, true or false?
Oh, you bend with the knee.
Yes. So you have to bend at your what? The knees. Okay, especially. Okay, not the waist. All right. And anything that you are lifting, at least it should be very close to the patient. Okay, it shouldn't be far from the patient. So that's the correct way of lifting things. You should keep the things close to you. All right. So, and if you are also rising, you want to rise up, okay, just try to use the legs. Okay, you stand on your legs to rise.
No.
Rather than just pulling with your back. Okay, and if anything that has to do with twisting, you avoid it. Are you okay, please? Are you okay?
Yes, boss.
So just teach the patient correct way of doing that. Okay. All right. So we are going to end here. God willing, next week we are going to start with rheumatoid arthritis, okay, and osteoporosis. So please may read around them. Okay. So that is what we are going to do next week. Any question?